All right, good afternoon, everyone. Thank you for joining us today for the Family Medicine Grand Rounds. Next slide, please.
Sorry, Catherine. There we go.
So here's the activity code for today. I'll leave this up here for a bit so you can all claim your CME credit. And this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that the Grand Rounds will address. Next slide, please. And then Dr. Nato has a brief introduction for us.
Well, thank you. Dr. Erica Sher is a fellowship-trained pediatric otolaryngologist. She completed her residency in otolaryngology at SUNY Upstate Medical University in Syracuse, New York. She completed her fellowship in pediatric otolaryngology at Boston Children's Hospital. Dr. Sher is currently an assistant professor in otolaryngology at UT Health San Antonio. Welcome, Dr. Sher.
All right, thanks for the introduction. Can you guys hear me over there? Do you guys, if you can't hear me, you can scoot forward. I know I'm not the loudest person in the world. All right, so today I'm going to be talking about ENT for primary care. And as was mentioned, I do pediatric otolaryngology, so most of this is going to have a pediatric focus, which I think is fitting though, because I think most of the ENT complaints that show up in a primary care setting are related to kids anyway. So our goals for today, we're going to describe some of the common pediatric otolaryngology problems encountered in primary care. We're going to review some of the key clinical practice guidelines that shape our management, and then we'll review both medical and surgical management options for these problems. There's a little outline. In keeping with being an ear, nose, and throat doctor, I'm going to try to cover the ear, nose, and throat. I do have a lot on this presentation though, so it's possible we might not get through every single slide, but we'll see how we do. So to start, we're going to talk about some common things like ear infections, how to manage hearing loss in children, earwax. We'll talk about some sinusitis and nasal congestion, management of nosebleeds, and then lastly, looking at tonsil issues, tonsillitis, sleep apnea, everyone's favorite tongue and lip ties, as well as the child with noisy breathing. As I mentioned, I'll be referring to some of the key clinical practice guidelines. So these are going to come from both the American Academy of Otolaryngology. We have clinical practice guidelines and clinical consensus statements that are available online for anyone to see, as well as some of the guidelines from the American Academy of Pediatrics. And for some of them, I'll talk about where we differ in our guidelines as well. All right, to start, ear infections. So why do we care about ear infections? Obviously, it is a very common problem in kids and probably one of the most common presentations to an urgent care for a sick visit. Definitely one of the most common complaints we get in our ENT office. And by age 6, only 40% of children have had 3 or more ear infections, so extremely common. Most people will have experienced it. At any given time, about 20% of school-age children probably have middle ear effusions impacting their daily life. And it's thought that acute otitis media to treat and manage costs about $2.9 billion a year. So certainly a very big problem. So it's important that we all know appropriate management for it. So to start, a few definitions, and in the ENT world, we're kind of picky with these definitions because it's sort of the foundation for how we decide to manage the patients. So acute otitis media, that's the rapid onset of signs and symptoms of inflammation in the middle ear. Recurrent acute otitis media is 3 or more documented and separate episodes in the last 6 months, or 4 documented and separate episodes in the last year, with one of them being in the last 6 months. And our literature is pretty specific that these should be separate episodes. They should not be an episode that was incompletely treated or didn't respond and required a second set of antibiotics. That would all count as one episode. Otitis media with effusion. So this is just the presence of fluid in the middle ear without signs or symptoms of acute otitis media. So that may be the kid that they're coming in for something else, and incidentally you just say, hey, they've got fluid behind their eardrum, but they're asymptomatic. And then chronic otitis media with effusion. So this is the child with otitis media with effusion. So not acute otitis media, but just a middle ear effusion that lasts 3 months or longer from the date of onset. Or if the date of onset is, or diagnosis is, or onset is not known, it's the date of diagnosis, meaning if the family or doesn't know when it started, it's the date that I diagnosed it when I saw them in clinic. So unfortunately, that does mean there are kids out there who are going to have fluid for longer than 3 months, but because it's not been diagnosed before, we don't know exactly when it started. So how do we diagnose acute otitis media or a middle ear effusion? So obviously, the biggest thing is going to be our physical exam, looking in the ear with our otoscope. We can also use other tools like tympanometry or a pneumatic otoscopy to help make the diagnosis of an immobile eardrum. And most importantly, we should not be diagnosing acute otitis media if we don't actually see fluid behind the eardrum. So the presence of just a red eardrum does not necessarily constitute a diagnosis of acute otitis media. And then this picture here, this is a pretty classic example of an acute otitis media where you see that white actual purulent effusion sitting behind the eardrum. So who needs antibiotics? And this actually does come from the American Academy of Pediatrics. So not every child with an ear infection is required to be treated with antibiotics. They do start this statement at 6 months just because they don't have data to support anything for children under 6 months. But I think most people would assume if you're under 6 months, you should get treated. But for children who are greater than 6 months with severe signs or symptoms, meaning severe pain or fever, should be treated with antibiotics for their ear infections. In children between 6 months and 2 years who have bilateral ear infections, even if they have mild symptoms, if they have bilateral acute otitis media, should be treated with antibiotics. For the other kids, so children who are between 6 months and 2 years, that have just a single side of acute otitis media, but not severe symptoms, you could consider observing them and seeing how they do. And similarly, children who are over 2, even if it's bilateral, if the symptoms are not severe, meaning no high fever, no significant pain, you could also continue observing them. The idea being that most of these episodes are going to be virally mediated and will resolve on their own, even without antibiotics. They do recommend, however, ensuring follow-up in about 48 to 72 hours to make sure that symptoms haven't worsened and that the child's doing well. And I think that's where it's difficult for most practitioners because everyone has a busy schedule, and so it's not always feasible to have every child come back in 2 to 3 days to recheck the ears. Again, this is from the American Academy of Pediatrics. So this is their algorithm for which antibiotics we should be using for ear infections. So the first line treatment is they do recommend high dose amoxicillin or Augmentin for patients who are not penicillin allergic. And I will be honest, when I have tried to send this into pharmacies, I have gotten a lot of pushback about the dosing in town. They don't like that 90 mg per kg per day dosing. And it has almost always generated a phone call from the pharmacist. And so I don't know if anyone else has had that experience, but I do find that a little frustrating sometimes. Alternative treatments, if you're penicillin allergic, would be something like Cefdinir. Generally, I know we try to avoid things like ceftriaxone, although of course, if kids are failing PO antibiotics, they do tend to get that course of 3 shots. And then for second line treatment, so say you have failed the first line, so if you failed amoxicillin, moving on to Augmentin or Rocephin, you can certainly try clindamycin as well. If children are really failing all PO antibiotics, they failed Rocephin and they're still highly symptomatic, they're still having high fevers, then that's a time they probably need to get sent to the hospital for admission for either something IV or even consideration of an acute ear tube. Truthfully, the number of kids who end up needing an acute ear tube is very, very low, but that's sort of the case where I would start to think about it if they've really failed everything. And then I do want to point out, because somewhat frequently we see kids who have been treated with like zithromycin. That is not anywhere on their algorithm and really not recommended to treat acute otitis media. Yeah.
Some of them just one dose, and it even says there one day, one dose.
I would say
Give them 3?
so we do not have the ability to do it in our clinic. I would say most commonly I have seen 3 doses though.
Okay, but I mean, that's what there's.
Yeah, they do say. Yeah. Yeah, I would say most commonly I see the UT pediatricians and UH doing 3 if they can get the kids to come back. Yeah. Yeah.
I have one more question
Yeah.
about otitis media with infusion. Right?
Yes.
I mean, so a lot of that's distinguished by the fact that it's not red, right? So where's the itis part? It's not really that inflamed, right? I mean,
So it would be differentiated really for acute otitis media. It would be more of a purulent effusion of the eardrum. This for just chronic otitis media, it's going to either look serous, so it may even look yellow, or just kind of cloudy if it's kind of a mucoid effusion. Yep. Yeah.
But it's not really inflamed, right?
Correct. It is not. That's a good. That's the Latin derivative. Yeah. So that I guess that's the difference. I don't know the answer to that. Different, but yeah. So instead of changing it from otitis, they use acute to differentiate. All right, so ear infections from an ENT point of view. So this is from our clinical practice guidelines and how we decide who we're going to be offering ear tubes to for recurrent ear infections. So one of our recommendations from our academy is that the presence of fluid should be assessed with either pneumatic otoscopy or tympanometry. Here we almost all have audiologists in our clinics with us, so we tend to get a lot of tympanometry because that is available to us. So you will probably see that in any notes you get back from us that we've gotten an audiogram. It's recommended to evaluate all children who are at risk for speech and language development problems for otitis media with effusion. So if a child comes to us and one of their complaints is speech delay, we will always get them a hearing test as well to help assess for that. And then they have different times they recommend to screen for children who continue to have speech issues. However, symptomatic children, so children with no ear infection, speech is developing normally, there's no concerns about the hearing, there's no recommendation to be routinely screening their ears for chronic effusions. Now, for kids who are, again, low risk, speech is developing well, no one has any concerns about their hearing. If you see that they have a otitis media with effusion, so not an acute otitis media, but a non-inflamed ear, it is recommended that we observe them for at least 3 months to see if they can resolve that fluid on their own before offering ear tubes. We do see this very frequently, that kids are put on varying like steroids, Flonase, antihistamines, decongestants, and things to help try to resolve their eustachian tube dysfunction and their chronic fluid. Really not recommended by our academy, particularly for the younger kids. There's not really any good evidence for isolated ear symptoms alone that those medications help. Now, certainly if you have kids with a predominance of nasal symptoms, there may be a role for them in our older children. So say age 6 and older, where you expect them to have outgrown their ear problems, that does tend to be more of an allergic mediated phenomenon then, and they may benefit from some of those medications. But your typical 1 and 2 year old getting a lot of ear infections, has fluid behind their eardrum, it's not really recommended to use any of those medications for the ears. And then if the fluid lasts for longer than 3 months, we do always recommend at least having a hearing test to document that the hearing is, because if there is concerns about the hearing at that point, they may benefit from ear tubes. So again, who's getting tubes? So kids with otitis media with effusion, longer than 3 months. So that's our category of chronic otitis media with effusion, documented hearing difficulties or other symptoms. We will offer ear tubes for kids with recurrent acute otitis media, and this is sort of the key for these kids. When we see them in clinic, they have to have fluid behind their eardrum to be offered ear tubes. If their ears are perfect when we see them in clinic, we will not usually offer them ear tubes unless there's other circumstances, such as they don't tolerate PO antibiotics, they've gotten Rocephin a bunch of times, they've had a hospitalization for their ear infections, things like that. Then we may offer ear tubes, but for your average child with a lot of ear infections, if we see them and the ears are perfect, we almost never will offer them ear tubes. And the reasoning is the tubes themselves don't actually reduce the ear infections. All they reduce is fluid sitting behind the eardrum. So there isn't much benefit if they don't have that chronic effusion. And then again, these at-risk children, so kids with speech delay, concerns for behavior related to the hearing, concerns about hearing loss, those are children who we may offer ear tubes as well. And these are just some pictures of different ear tubes that we can use. They can come in varying colors. They're frequently blue, white, they can be black. There are some that look kind of metalish. There's some that are gray, and they can have varying shapes as well. So if you look into someone's ears and see something funny, it's probably an ear tube and not to be worried if it's a funny color too. So just a little bit information about the ear tubes. They do have a variable duration. The most common ones are designed to last about a year and fall out on their own. Some will be shorter. We consider it normal for them to last between 6 to 18 months. However, we do have longer lasting ones that can last for years that we tend to use for people who are on their second or third set of ear tubes, or maybe they have a reason why they're going to have prolonged eustachian tube function, like a cleft palate. They can be placed in varying parts of the eardrum without a problem. We tend to put them inferior, but they can also be superior without a problem frequently. We do follow the children until the tubes have either fallen out or we've decided to take them out, despite sometimes patients may come back to you and say, I haven't seen the ENT in 3 years since the kids' ear tubes were placed. I promise we gave them a follow-up. They just never came. And for people with ear tubes, it is possible to get ear infections still. However, they will always present with otorrhea, so you'll have drainage coming out the ear. You may not always see it just from outside. It may be present when you look with an otoscope, but if there's no otorrhea, should not be treated as an ear infection. And then for kids with ear tubes, the first treatment for that otorrhea is always going to be ear drops. Generally, we use Ciprodex because it's readily available for us. However, some insurances don't like to pay for it because it's very expensive. And so if someone's insurance doesn't want to pay, ofloxacin is a good alternative to it. And you can even use dexamethasone ophthalmic drops with it to get the same combination that's in Ciprodex. The only thing we would recommend to try to avoid is cortisporin drops, because the mycin in it is theoretically ototoxic. So you don't want to put it in an ear with an open eardrum, theoretically. Yes. Cortisporin drops. Yeah, they have neomycin in them. And so the aminoglycosides are, as long as there's not aminoglycoside. So cortisporin or Ciprodex has just ciprofloxacin. And ofloxacin obviously is just ofloxacin. So those are fine. And truthfully, people use cortisporin without a problem, but it's one of those theoretical risks, and you don't want to be the person to give someone hearing loss from it. All right. Yeah.
What else in terms of care of the tubes? Swimming and other activities.
So we tell them for bath time and swimming in a swimming pool, they do not necessarily need to do anything special. They do not need earplugs unless they're having like an active ear infection, then they should keep the ears dry. But for the average child, they will not have problems bathing or swimming. If they're going to be in dirty water, like a freshwater lake or a river, I do usually recommend earplugs at that time, but otherwise they don't need water precautions anymore. All right, hearing loss. So as we all know, in I think every state in the country now, everyone does a newborn hearing screen for children who are born in the hospital. The current recommendation is that all infants who are born in a hospital get a hearing screen before they are discharged. So it's important to know they have to be born in the hospital for that to happen. If they're born at home or they're born in a birthing center, they won't get their hearing screen. And so that is important to follow up with the family on, because we have seen that happen where they were born out of the hospital, never had a hearing screen, and showed up 3 years later and couldn't speak because they had no hearing. So important to keep in mind. If there is concern for hearing loss on the newborn hearing screen, the current recommendation is to have confirmatory testing by age of 3 months to confirm that they have hearing loss or that the hearing is normal, and that can be arranged directly with the audiologist. It does not need to go through an ENT. And here in Texas, I think there's quite a few there's at least the UHS audiologists are very good about doing that, and there's also Sunshine Cottage can help families do that confirmatory testing as well. Once hearing loss is confirmed, the current recommendation is to have an intervention, meaning hearing aids, in place by 6 months. And that it can be a hard goal here. However, if we're ever able to accomplish that, then the next step is to try to do it as a 1 to 3 month goal, but meaning diagnosis at 1 month, confirmatory testing at 2 months, and hearing aids by 3 months if we can. If somebody is diagnosed with hearing loss, there are other tests that we can do to try to help elicit the etiology of the hearing loss. And some of it depends on what the kind of hearing loss is. So if children are diagnosed with a sensory neural hearing loss at birth, CMV testing is very high yield actually. However, it does have to be done usually within about the first 3 weeks of life. After that, it's very hard to distinguish between a congenital and an acquired infection. And so the results cannot really be utilized as such. I have heard of cases where they were able to later use the newborn blood spot to test for CMV, but I personally don't know how you go about doing that or who would have those resources here in Texas, but it's potentially an option. For all children with hearing loss, we do recommend having ophthalmology evaluation throughout their life because we want to make sure that we're optimizing their other senses they have a known hearing. There are also syndromes with hearing loss that can be associated with eye abnormalities as well. So we want to make sure we're catching those kids. Some of the children, particularly if there's a family history of any heart defects and they have hearing loss, we would recommend a cardiology evaluation. Not all children with hearing loss need that though. For the most part, we are offering genetic testing to most children with a sensory neural hearing loss. We do sort of counsel them though that this doesn't usually change the outcome of their hearing loss. Their child will still have hearing loss. It's not going to cure it, but it can give the family a little more information, can help with family planning in the future. And I also do always counsel them that it may not show them anything, or may give them results that they don't know them we don't know yet. And then lastly, getting some otologic imaging of the ears. Again, this depends a little bit on the hearing loss, how much hearing loss they have and the kind, whether we get it or not. And also if we're going to be needing it for a surgery such as a cochlear implant. For children who can just be managed with hearing aids, we may not always get that imaging right away. These are some guidelines for how we follow hearing in children for the child who actually passes their newborn hearing screen. There are a lot of children who fall into this high-risk category of developing hearing loss later and need to be routinely screened. The biggest thing is going to be children who have a somewhat prolonged, meaning more than 5-day NICU stay, all need to have repeat hearing testing around age of 9 months. And other ones like someone being on ECMO, they should be getting repeat screening within 3 months of that. Similarly, if a child's diagnosed with meningitis, they should be getting rescreened about 3 months after the illness. So this is just a good thing to keep in mind when you're thinking about when to rescreen children's hearing. And again, this all just goes through some of these other high-risk populations that need repeat screening, even if they passed a newborn hearing test. All right, so I think this is my last ear topic, is ear wax. So obviously this is a big problem. Parents seem very bothered by it in their children for some reason, and they always talk about how much wax their child makes. So the biggest thing is no Q-tips in the ear. I have seen a patient whose mom was cleaning the ear with a Q-tip and they went right through their eardrum and created a huge hole and a big problem for their child. So no Q-tips, no Q-tips, no Q-tips. It just pushes the wax further in and makes it hard to clean anyway. If you know that they have an intact eardrum, they can use the medication Debrox. If you don't know that the eardrum is intact, that there's a chance there's a hole in it that we just don't know, we usually will just recommend any sort of oil, mineral oil, baby oil. They can even use olive oil in their ears. All it does is help soften the wax so that it can work its way out on its own. The ear by nature is a self entity, so sometimes it just needs a little help to keep the wax soft. And then lastly, we do sometimes utilize antibiotic drops, so we can always use Ciprodex or Ofloxacin if you needed to. But most people do fine using baby oil, basically. And I just tell them they can get it at any pharmacy with like an eyedropper and put a couple drops in each ear a couple times a week. Any other ear-related questions? All right, onto the nose. So nasal congestion, sinusitis, again, a very common problem in kids. Starting from the first day they go to daycare or school, it seems to be almost instantaneous. They get nasal congestion. And in kids and everyone, there are a few areas where you can have obstruction. So the first being in our turbinates at the front of the nose. Most commonly, the inferior turbinate can get enlarged. Happens if you get a cough, a cold, allergies. And then in kids, it's very common to have enlarged adenoids. So for those kids, they have kind of chronic postnasal drip. They're going to have that open mouth breathing. I'm sure you've heard of children having adenoid facies. If they have really big adenoids, they have this sort of open mouth, long-faced posture where their midface almost looks longer, and they kind of just always have a slack jaw because they're breathing through their mouth. And then obviously the sinuses can be an area of infection and obstruction. So one thing that's important to know is children are not born with all their sinuses. Your sinuses do develop over time and generally don't finish developing until teenage years or later. And so sinusitis in children under age of 12 tends to be actually more of a chronic adenoiditis phenomenon. And our guidelines recommend of the adenoids before addressing sinuses in children of that age. So to begin for nasal congestion, what are our medical management options? So the mainstay is always going to be nasal saline sprays or those sinus irrigations that they can get over the counter. There's varying ones. Some are kind of more gentle drops for the little kids. As people get older, they can use the big irrigations where you're shoving like a whole like 2 syringe of saline up your nose and it gets all the boogers out. Those do work very well for most people. Intranasal steroids like Flonase and Nasonex work very well. For those with an allergic component, intranasal antihistamines like Astelin are available and again work well. The oral antihistamine, Nurtec, Allegra, things like that are available, and then Singular. And then particularly for some of the older kids, so again, age 6, allergy testing can be very, very useful, particularly here in San Antonio. A lot of kids are allergic to like Bermuda grass, oak trees, things that are just really prevalent out in all of the neighborhoods and can make people be very symptomatic. One thing that our academy, I was just at a meeting and they were talking about, because when we all frequently order RAS testing because it's a blood draw, easier for the kids than doing a skin prick allergy testing. And there's an option to do it for food allergies as well. Our allergists do not recommend drawing it for food allergies unless children are actually symptomatic, meaning, they're getting hives when they eat something, because otherwise they don't usually recommend avoiding foods just based off off the blood draw if they have otherwise been asymptomatic. So they like it for the inhalant allergies, but not so much the food allergies. So sinusitis. Chronic sinusitis is 90 days of 2 or more symptoms, meaning purulent nasal drainage, nasal obstruction, face pressure, pain, cough, and either endoscopic signs. So that's what that picture on top is. When we look in the nose with a camera, we see these kind of watery looking polyps or CT scan changes that show polyps. And so that's kind of look for when we're thinking of somebody with sinusitis that might need sinus surgery. And it's really important that if any child has true nasal polyps, they do need to be tested for cystic fibrosis. Nasal polyps are very unusual in a child who does not have cystic fibrosis, even here in San Antonio where allergies are high. Adults is a little different. You can have nasal polyps without having cystic fibrosis. So I would say it would be a little unusual for an adult to make it that far without having a diagnosis, although not impossible in this. But really any child with a nasal polyp should be tested for cystic fibrosis. For sinusitis, so the recommendation is for culture-directed antibiotics, and that would just be a nasal swab to essentially to make sure that it's not MRSA, or treat it if it appropriately if it is MRSA. We do usually recommend a prolonged course of antibiotics. So they have done studies showing that a course of at least 20 days of antibiotics can be more beneficial than a short 7 to 10-day course. And then this is, of course, in conjunction with our nasal sprays and nasal steroids as well. And as I mentioned, so from a surgical standpoint, for our kids who are 12 and under, the current recommendation for sinusitis would be to perform an adenoidectomy first. Most children will have resolution of their symptoms with the adenoidectomy. And then if you've done an adenoidectomy on a child and they're still having sinus infections and you've tried management, then you start to look more into performing formal sinus surgery on them. And then epistaxis, very, very common, particularly in kids, because they like to pick their nose. The most common source is this area at the front of the nose called Kisselbox plexus. That's where all of these different blood vessels converge. And it is the most accessible for little fingers to get. To start, we almost always will start kids with some ointments and nasal sprays in the nose. So we like to give Bactroban in the clinic and have them squirt it up their nose before they go to bed and when they wake up in the morning. And then instead of blowing the nose during the day, if they're feeling congested, use those nasal saline sprays again. It works well with just regular Vaseline as well, too. You don't have to use Bactroban. Afrin can be used for active bleeding episodes only, and you have to make sure that they're not using it on a daily basis because they're going to feel great because they can breathe through their nose again. But Afrin use for more than 3 to 5 days is associated with a rebound congestion, and it's very hard to wean patients off of it once it's happened. Very, very, very difficult. And if you have a teenage boy with unilateral epistaxis, that should really get sent to an ENT for evaluation. We need to scope their nose because they can have something called a juvenile angiofibroma, which is a tumor of the nose. Typically only presents in teenage boys. And so they need to be scoped in clinic to make sure that's not what's going on.
So where does this occur? You see with that nasal laryngoscope, I assume.
Yep. So we tend to see them in our middle meatus, so kind of high up between the middle turbinate. It would be pretty tough to see it from the outside, yeah. So yeah, that's somebody I will always scope in clinic if they come. Uncommon tumor, but again, you hate to miss it. Those questions?
So for sinuses, like to me, are really difficult because you never really know what's in there, right? I mean, you guess that the bacteriology, you almost never get a real sample. Even you say you swab it, you're really trying to find out for colonized.
Yep.
With MRSA, but you don't ever really know what's going on.
Yeah, and truthfully, even if we were doing, you know, we can, if we're taking someone to the OR, we can put the swab directly in their maxillary sinus. But theoretically, you know, unified airway theory, whatever's there should be in the rest of the nose as well. So a swab should be, even at just the front of the nose, would probably be sufficient. If you're able to get, you can get a nice mucus.
That's good. So it's been pretty well shown that what's on the outside, which is swabbed, and on the inside, that sinuses as well.
So it should be, I mean, so if you have drainage coming from the sinus, if you're able to get, you know, it's going to drain out.
Yeah.
If you get a good sample of the drainage.
See the hospital, right?
Yeah. No, you should be able to see it. You know, it'll come down onto your inferior turbinate eventually. Yeah. So we usually send Flonase because Superior Medicaid covers it for our patients.
The culture, very soft. So would possibly just detecting from our system near, it's like they're not tolerant or like wait to see what it grows.
I would wait to see what it grows. Yeah. All right, so tonsillectomy. So tonsillectomy is the second most common surgery in kids after ear tubes, and almost 300,000 tonsillectomies are done a year. So very, very, very common surgery. Our two indications are going to be sleep apnea or sleep disordered breathing. That is by far the most common reason to take out tonsils and adenoids these days. And recurrent throat infections or recurrent tonsillitis is far less common. Now there are pretty graphs out there in the world that will show you, at some point recurrent throat infections or tonsillitis was like the only reason they were taking out tonsils, and everyone got their tonsils removed for that reason. And probably starting in maybe the 80s, that indication really, really dropped, and sleep disordered breathing or sleep apnea has really taken off as the biggest indication for surgery. So from a tonsillitis standpoint, who are we offering surgery to? So that's based off this Paradise criteria. So this is what we're kind of looking for when we see these patients: 7 episodes of strep throat or tonsillitis in 1 year, over 2 years, 5 episodes per year, or over 3 years, 3 episodes per year, with some of these other symptoms like fever, lymphadenopathy, exudates, or a positive strep test. Now, of course, there's some modifying factors. So somebody who doesn't tolerate antibiotics anymore, has allergies, that's somebody who we would still consider surgery on. Somebody with a periodic fever syndrome, we do frequently take out tonsils for that, and they do seem to do somewhat better, not always though. And then if you have more than 1 peritonsillar abscess here, you kind of qualify to have a tonsillectomy. I think most parents are very surprised when we tell them these numbers. Because they kind of come and say, oh, my kid gets strep once or twice a year, I want their tonsils out, and we have to tell them no, and they're a little surprised. So our more common reason to take out tonsils these days: sleep disordered breathing or sleep apnea. So sleep disordered breathing are abnormalities in the respiratory pattern, including snoring, mouth breathing, and pauses. Specific for kids, it can be associated with daytime symptoms of inattention and poor concentration and hyperactivity. And this is a little contrary to what we see in adults. So adult sleep apnea tend to have more fatigue-related symptoms. They're the ones falling asleep while they're sleeping. Kids, it tends to be the opposite. They're the kids who cannot sit in their chairs at school, and the teacher can't control them. And then for a diagnosis of obstructive sleep apnea, these are kids who have the symptoms of sleep disordered breathing with a sleep study showing sleep apnea. So these are the categories that we use for obstructive sleep apnea in kids. I do think the numbers are a little bit different from the pediatrics world, but for us, we say from an apnea hypopnea index of 1 to 5 is mild sleep apnea, 5 to 10 is moderate, and severe is greater than 10. And then this is very specific to kids. So in adults, we say 1 to 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and over 30 is severe. Now, there is some debate about when do you stop using the pediatric criteria and start using an adult criteria. For most of medicine, we say 18 is kind of when you make that change, but I think most people would agree that a 3-year-old is quite a bit different than a 16-year-old. And so I think for most people, usually around 13 to 14, depending on the child's development, they may make that distinction of they seem to fall more under the adult criteria.
A lot of younger patients, their tonsils will just be normally bigger, and then they'll influence a little bit over. So how does that figure into this decision?
So from our standpoint, it really just depends how the child is doing. So if you have mild sleep apnea, as you mentioned, those tonsils do tend to get smaller over time. And our literature shows that if you wait on a kid who has mild sleep apnea, they are probably going to get better on their own. So if the parents feel like they're doing okay and they're doing, they're getting good rest, they're doing okay in school, and the fatigue, they're not having a lot of issues, it is totally fine to wait and not operate on them. For the children who are starting to get into more moderate to severe. So I recently had a patient with an AHI of 135. That was not going to go away even if her tonsils shrunk. So for those people, the recommendation is to offer surgery.
Okay.
So one thing is, we don't have a sleep study on every child. It's not possible to get one on every child. We would overwhelm the sleep lab. There are some recommendations for who would benefit from a sleep study. Is where our recommendations do differ a little bit from the American Academy of Pediatrics. We tend to recommend it for very young children and for children who have some of these other medical comorbidities. And then specifically, if the need for tonsillectomy is uncertain, meaning the history that the family gives is either not reliable or maybe they're eliciting some of the symptoms, but they say, actually, I think the child might be fine. I'm not really sure. Maybe I don't listen to them at night because they're sleeping in their own room. So that's somebody who would benefit from a sleep study to help with the decision making. And then a discordance between exam and reported symptoms. Certainly somebody who the family's reporting a lot of symptoms, but you look in their mouth and their tonsils are tiny, or maybe they've even already had a tonsillectomy, that's someone who should definitely be getting a repeat sleep study before you're offering them any other interventions. And then from the American Academy of Pediatrics, they, I think, have a lot more categories of people who would benefit from a sleep study. You know, anyone who snores, anyone who maybe has just big tonsils. I will say, I think it depends a little bit on people's insurance, whether the insurance will approve it based off some of those criteria, truthfully.
So
Yeah.
some insurances want you to get home sleep studies. Can you get the information you need from those, or do you use that?
They're not recommended for children. It's not approved for children. So we haven't gotten any pushback from insurance that they say, oh, you have to do that for a kid, because it's not approved. Yeah. And then who do we keep in the hospital after surgery? A lot of healthy, you know, a healthy 6-year-old getting their tonsils out who lives here in town. A lot of times we send home after surgery. They don't have to stay in the hospital. Again, our really young kids, we're going to keep in the hospital, kids with more severe sleep apnea. So from our standpoint, we say anyone with an AHI over 10 is going to stay in the hospital. The American Academy of Pediatrics puts their criteria actually at an AHI of 24, which is much higher than ours. So we tend to keep everyone, though, over an AHI of 10. When it starts to get really high, the sleep's really bad, we do consider keeping them in the ICU overnight, and we will sometimes start children on CPAP while they're still in the hospital post-operatively. So usually it's a one-night stay, but for some of the more severe kids, if I've needed them to start CPAP and go home with it, they will end up in the hospital for a few days while we're arranging for CPAP for home. What is normal after surgery? So if you ever look in someone's mouth who's had their tonsils out within the first 2 weeks, it looks terrible. It really looks like a bomb went off in there, and that's totally normal. They always have this whitish, grayish look where their tonsils used to be. The uvula looks like a golf ball in the back of their mouth and might have that white stuff all over it as well. That is totally normal. It is not an infection. It is not thrush or anything like that. It always smells terrible as well. Their breath is terrible for about 2 weeks. That is also normal. Very common to have some fevers. Their ears frequently hurt. That's referred pain from their throat. And yeah, it looks bad until for about 2 weeks, and then it gets better. Post-op care, what we recommend, so the biggest thing is just drinking lots and lots of fluids so they don't get dehydrated. We do recommend a soft diet for 2 weeks, and I just tell them nothing that's going to poke or scratch you, so no pretzels, pizza crust chips, things like that. We do keep them out for at least a week. Some of the older kids, because their pain is a little worse after surgery, will be out of school for 2 weeks and out of sports for 2 weeks. For the most part, people have moved to just Tylenol and Motrin for post-op pain control. And that tends to work very well for the younger children, doing that around the clock, and they can alternate it. So they take Tylenol, 3 hours later, 3 hours later, Tylenol. For the older kids, the teenagers, most of us will usually still write for a couple of days of narcotics just because their pain is considerably worse than the younger children. However, with the exclusion of kids with really bad sleep apnea, we will not send home with narcotics due to the risk of respiratory depression. They're already bad at breathing. We do not want to make it worse for them. And then a lot of times we will also send them home with some prednisone or other steroids because we find that also helps with the pain, reducing the parapharyngeal swelling. Any questions about tonsils? All right. Tongue and lip ties. I know this has been, over the past few years, been a very hot topic, popular topic. And I think even recently now, there are articles coming out saying, hey, maybe we've overdone it on this. People are kind of, it's always in the news. So I personally haven't found any overarching way to categorize these tongue and lip ties. When you Google it, there's a bunch of different classifications you can use. I think most people would agree when you see something like in the top row where that connection goes to the tip of the tongue, they kind of try to stick it out and it doesn't really go anywhere. That's a tongue tie. People talk about these posterior tongue ties, where you don't see anything, but maybe there's some sort of submucosal connection that you can feel. I will be honest, there is a statement from our academy that says there is no definition of what a posterior tongue tie is, and we're not sure what it is, and it is probably not a real thing. And then similarly, lip ties, people have different classifications. But again, there's no overarching way to describe these things. So for tongue ties, so what does this actually mean? So all it would be was a limited tongue mobility caused by a restrictive frenulum. And I tell all the parents when they come, everybody has a frenulum. We have to have a frenulum. Otherwise, our tongue would just be flopping in the back of our throat and obstructing our airway the whole time. So the idea of a tongue tie is this frenulum shorter than average, and is it causing difficulties moving the tongue? We do know that this can be a cause of maternal pain and poor latch for breastfeeding, but there's also a lot of reasons for someone to have problems with breastfeeding, unrelated to a tongue tie, that need to be evaluated. In an ideal world, anyone having trouble breastfeeding with concerns for a tongue tie should be evaluated by a lactation specialist, feeding therapist. I don't think that is reasonable for most people, though, to accomplish before trying to see a dentist or an ENT to address it in a timely manner. And then I always get a lot of questions, if we don't do anything about it, maybe my child's feeding okay, but I'm worried the child's going to have like dental problems, speech problems, feeding issues in the future if we don't address it. So maybe we should just deal with it now. And our Academy's position statement is there's really no way to predict who is going to have speech problems, who is going to have feeding problems. And most speech or feeding problems are not going to be related to a tongue tie. So it is not recommended to do like a preventative lingual frenulotomy to try to prevent those issues in the future. I always counsel patients there's risks to any procedure, and while the risk of cutting a tongue tie is generally pretty mild, bad things do happen, and people are very unhappy when it happens to their child. So risk of bleeding is there. Again, it's a very small risk, but there are cases out there of someone cuts a tongue tie in clinic and then is running this child to the operating room to stop bleeding that they can't control in clinic. You can airway obstruction, there are salivary structures nearby. I have heard of kids getting an oral aversion because they got a tongue tie cut, and then the parents were doing really aggressive tongue stretches that was like hurting them and opening up the wound every time. And so then a kid who was maybe eating okay is now not eating. You can get scarring of the area, causing the tongue to be tighter than it previously was, and you may not get, truthfully, any improvement. If you look online, there's like 1,000 posts on Reddit of people saying, oh, I had my kid's tongue tie revised 3 times, and it took, 6 months after the tongue tie revised before they had any improvement. I think most of us agree it wasn't related to the tongue tie at that point, but they really think that 3rd revision did the trick for them. There are contraindications, so not every child is going to be a great candidate for it. So kids with small jaws, recessed jaws, if they're kind of hypotonic, those are kids I would really think twice about cutting a tongue tie, because again, you can cause a problem with their tongue flopping back and causing an airway obstruction issue. And certainly kids with coagulopathies or cardiac kids on aspirin, I would really think twice about cutting a tongue tie in clinic, because you could get into a lot of bleeding that's hard to control. Lip ties. So the presence of a labial frenulum is totally normal in babies, even for it to go all the way down to the tip of their gum. That is considered normal. It's the most common configuration in a baby and an infant. The labial frenulum is a dynamic structure, so when they look at it over time, it will naturally rise up as the child ages and grows. And there's really no research out there to suggest that there is a clear relationship between its presence and any difficulty with breastfeeding. And when they've tried to do studies to see does clipping it improve breastfeeding, there's been no conclusive evidence of that. Parents love to ask, is this going to cause a gap between my child's teeth? Maybe, maybe not. A lot of children will have a gap when the baby teeth come in, and it's actually thought that this labial frenulum may be holding space for when the adult teeth come in, because the adult teeth are going to be bigger than the baby teeth anyway. And most of the time when the adult teeth come in, there is no gap. From the dentists themselves, they have a statement about this, and they do not recommend cutting it for concern of a gap in the future, and that they would just address it in the future if the adult teeth come in, the gap thought to be related. They would address it when they do orthodontics. Occasionally we get people talking about buccal ties. This is not a thing and shouldn't be done. Can absolutely make feeding worse to do it, because you're going to lose the tension of your cheeks, being able to suck and hold food in. And if parents are asking about it, I would not recommend it. It will not help their child. Any questions about those? Right. got a few more minutes. Perfect. So my last topic is noisy breathing. Because my favorite topic, because this is, I would say, a lot of our day as well, is getting little kids with noisy breathing coming in. So noisy breathing is super common in kids. And we tend to talk about stridor or stridor. So stridor is that sort of high-pitched noise. You hear kind of like a squeak, sometimes might sound kind of wheezy in quality, and can be described as inspiratory breathing in, expiratory breathing out, or even biphasic, depending on where our lesion is. And then stridor is more of that snoring sound, the kid who's just kind of really snotty with noisy breathing. You'll hear that stridorous sound. And noisy breathing is important to know about in kids because it's very common, and kids are more predisposed to airway obstruction for a few reasons. One, as we know, babies are obligate nasal breathers, so congestion in their nose can be really difficult for them. The back of their head is very, very large. If you lay them flat, they tend to come forward and will start to compress their airways. In general, their tongue is large compared to their oropharynx, so it makes it very easy for tongues to fall back if their tone is not normal. Their villages of their airway are much softer, and it's much easier to compress them. In general, their larynx is higher than in an adult. It does drop over time. And the narrowest part is going to be the cricoid ring. That is actually narrower than their vocal cords, which is the narrowest part in adults. In general, their airways are going to be very short. And so all that means is when they're sick, they get a virus, they have a lot less space to work with when you get a little bit of edema. We've talked about like the adenoids before, but adenoids and tonsils, again, can be large and start to obstruct the oropharynx. And baby teeth are loose and can fall out and also cause airway obstruction. So as I mentioned, stridor, that's the sort of high-pitched sound we hear, can be described as inspiratory, biphasic, or expiratory, and how it sounds, what phase it's in, can help guide where a lesion is. So inspiratory stridor, we tend to see in the supraglottic region, so that's going to be like our epiglottis, or above the vocal cords. You can sometimes have it at the vocal cords as well. Biphasic stridor tends to be right at the level of the vocal cords or right below. And expiratory sounds we think of as originating from lower down, so lower in the trachea or the bronchi. And when you start to hear these different sounds, it sort of helps us decide kind of what we're thinking about. Let's see, is this pointer? I don't know. And so when we're thinking about like sort of chronic inspiratory stridor, one thing we'll talk about in a second is laryngomalacia. That's the most common cause of noisy breathing in babies. When we're thinking of acute things, we're going to think more like infectious things or traumatic things in little kids. Chronic is going to be more of those congenital or sort of like slowly acquired things. So as I mentioned, laryngomalacia, that's the most common cause of stridor and most common congenital laryngeal anomaly. And all it really means is having a tightness or floppiness of our supraglottic airway. So the symptoms of stridor typically appear shortly after birth. In severe cases can kind of appear at birth or within the first few days, but more commonly probably around 2 months or so. It tends to worsen over the first year and then start to improve on its own, and symptoms generally will resolve on their own in 2 years. Typically, the symptoms are going to get worse when babies are lying flat on their back and when they're eating. And as I mentioned, due to this tightness or floppy tissues above the voice box. So this picture is how we would describe a tubular epiglottis. So it's creating complete obstruction over the voice box. And then this other picture to the side of it. So this is after treatment in the operating room. This is a procedure called a supraglottoplasty, where we make little the fold the side of the epiglottis to release it and allow it to open back up. Now, not every child with laryngomalacia will need surgery. Many can be managed conservatively or with observation. Things we look for are kids feeding well and gaining weight appropriately. Are they having symptoms of obstructed breathing? So are they having pauses in the breathing? Have they ever been had apneic events or had cyanotic events? if they have any of those things, then we start to move into management. But for a kid who may just have sort of a noisy sound to them, but is otherwise doing well, you can frequently observe them until they have resolution of their symptoms. For more severe cases, they may benefit from CPAP or BiPAP, or as I mentioned, even surgery. This particular surgery is a supraglottoplasty. For kids who are really severe and they may fail a supraglottoplasty, a tracheostomy would be the last resort for them. Croup is going to be the most common cause. Is going to be more of a chronic stridor. That's a stridor that shows a few days after birth and is present for a long time. The most common cause of acute stridor is going to be croup. This is due to a viral infection. Most commonly is going to be parainfluenza, but truly any viral infection can cause a croup-like symptom in kids. Most commonly between 6 months and 2 years. And as we all know, that kind of barky cough, and it can be associated with stridor. For most kids, they're going to do fine with just medical management and supportive care with some steroids and racemic epi. From an ENT standpoint, really our only role in it is if a child needs to be intubated while they have croup. Frequently, we might be involved to help get a breathing tube in. And then if children have recurrent croup, so 2 or more episodes a year, they fall in the category of recurrent croup. It is recommended to have them evaluated for an anatomic issue that could predisposing them to croup. So they may have like a congenital narrowing or subglottic stenosis. And we also start to think about potentially GI issues that can be causing chronic inflammation, such as untreated reflux or eosinophilitis. So subglottic stenosis. So this is going to be a fixed narrowing of the subglottis. This can present with either like an inspiratory stridor or very frequently a biphasic stridor. This can be congenital, so kids can be born with it. Again, this can be a cause of a recurrent croup. More commonly, though, it's going to be iatrogenic. So I'd say the most typical story we get is you hear of a baby who, say, was sedated for RSV for some time, and because they were intubated while they were having an inflammatory event going on, they then developed this subglottic stenosis. And I think these pictures are from a kid who that's what happened to them. And then they got extubated, they went home, and as they were home, they developed this stridor that got worse and worse until they came back in the hospital. And so their main symptom is going to be inspiratory stridor. Workup for them can include various imaging, but ultimately they're going to need a trip to the operating room to take a look. And then again, treatment just depends on the severity. On severe case, you may be able to observe it. The airway will grow with them, and so if they're overall doing fine, can observe. But for children with more severe stenosis, such as this child, they may need a procedure to dilate the airway. And severe cases may end up with a tracheostomy or a bigger airway reconstructive surgery to remove the stenotic area. Airway foreign bodies. So airway foreign bodies are not super common, and truthfully, although the incidence did go up during COVID as kids were home and putting things in their mouth and their ears that they shouldn't have been. The most important thing for airway foreign bodies is just to have a high suspicion based off the history alone. The symptoms of it are going to depend based off where the foreign body lands. So if it lands just in the vocal cords, as in this picture on the right, to the right of the screen, you can have a biphasic noisy sound. But if it ends up lower down, and most commonly it's going to be in the right main stem bronchus, it may be just a soft wheeze that you hear on that side. Most commonly, these tend to be food objects, which are radiolucent. And so when you get an x-ray, they're not going to you won't see anything. And frequently the x-rays are normal. Depending on how long it's been there, you can see some air trapping on the x-ray, but most commonly you're not going to see really anything. And so we tend to just take children to the operating room for this based off the history alone. And we'd rather have a normal look at the airway than miss a foreign body that we should have found. Let's see, epiglottitis. This might even be my last one. So as we know, this is a bacterial infection of the supraglottis, classically due to a H. flu infection. The incidence of this has gone very far down with the introduction of the H. flu vaccine. I will say I personally have never seen a patient with epiglottitis, and hopefully it stays that way. This is a rapidly progressive infection with rapidly progressive airway symptoms. And these kids, when they show up, will classically present in distress, and they sort of are leaning forward. They've got their neck stuck out, their mouth is open, they're drooling. They look very, very, very uncomfortable. And really, the most important thing is if you think a patient has this, is really they shouldn't be touched in the emergency room. They need to go directly to the OR for management of their airway. They should not be getting any labs in the emergency room. We shouldn't be getting x-rays. They shouldn't have an IV started because any of those things, if you upset the child, can lead to complete airway obstruction. So the recommendation is to go straight to the operating room and not draw any an IV until you have the airway managed appropriately. All right, so that was my last topic. I just want to put these up. There are a few references out there specific for ENT and primary care that are available. That I have looked at myself in the past, and they are quite good. And they're available out on Amazon and things for anyone to use. Great. Well, thank you for listening. I'm happy to take any questions.
When you told us that you were not in the US military, but if you had been, you would have been in a unit, and if you were in a unit, you'd have a unit coin, right? So this is our unit coin, so this kind of marks as an honorary family physician.
Oh, thank you.
This is the highly sought after, seldom presented, but always treasured Family and Community Medicine
Oh.
Challenge, just a
Thank you.
token of our
Thank you.
appreciation.
Thank you.